The test lacks high sensitivity, although EEG does not give you a high sensitivity. Okay. So that's about it from here. And then let's go from here. A quick read, I think. It's so it's a neurology. I'll just give you a quick read, not quick read, quick overview from here if I miss anything. Okay, just to an idea. I'm trying to find some of the PDF where I have write down the important topics from Toronto Notes. If I find it, I will share it with you, and then it will be more easy for you whenever you are going through Toronto Notes. Okay, so from here. In this neurology chapter, the main important is knowing about strokes and how, where are you going to do the what kind of treatment. That's about it. And I think we already read that one. So let me just give you an idea from here. So these are the main topics from here. So status epilepticus is important, how you're going to manage this case in emergency. So when we'll do the emergency, we'll quickly read it from there. Okay. Then I think we already discussed about the dementias. So mainly you just need to know the dementia so you can make the diagnosis of the dementias. Then the mild traumatic brain injury, that's important. We'll do this one from here. And I think we already discussed pretty much everything from here. Yeah, just whatever I told you about stroke, you need to know this much. You don't need to go a lot of into detail. Then comes the restless leg syndrome. Restless leg syndrome, like the causes, is very important. Okay, let's go to the traumatic brain injury. Here, the status epilepticus, just for your idea, the convulsive seizures more than 5 minutes. This is a page number 20 from Neurology. Okay. So convulsive seizures more than 5 minutes, treat as status epilepticus. So you're going to start with A, B, C, airway, breathing, circulation, then checking the vitals, laboratory investigation, checking for all the electrolytes. If any fever or meningismus, then go for CT scan and then finding out and starting the treatment for meningitis like antibiotics. Then checking, giving the glucose as well, just to make sure that this patient does not have hypoglycemia. Then lorazepam, just to control the seizures. Then fosphenytoin can be given or the phenytoin can be given. So you don't need to go into very detail of knowing how much the dosage is. Then ICU, and then continue the infusion of the midazolam to control all of that, and then burst expression on the EEG. So just for your idea how you're going to control a status epilepticus condition. And this one is more than enough for you to find out in any kind of confusion what kind of investigations you need to do. As you can see, mainly we do CT scan. But in some cases where you feel like it needs to be done a lumbar puncture, and I think we already know in which cases we need to do. So I think it's more than enough for you. And then I said that, what kind of disorder, so you can read it from here too. Then don't go into very detail when you do neurosurgery, especially from U word, it's too much. So you don't need that much. Like if you have time, just do the tables. That's about it. Then comes to the, I mean, this topic, it sometimes makes me feel like it needs to be read because I saw MCQs, I saw certain groups, people discussing this topic. So it's no harm to read and knowing how to make the diagnosis of this one. That's about it. Okay. Although it's not very, very important, but you never know. You could be the lucky one. Then comes the mild traumatic brain injury. In this one, you need to know the clinical impairment is basically the somatic, cognitive, and emotional. So later on, depression can come. Patient had an accident or any head injury, and then later on can present with the depression. So investigations during a neurological examination, cognitive, simple checking out the GCS scale, doing an X-ray, and then CT scan. So the main is this is treatment and prognosis. Okay. So the treatment is observation for 24 hours after a mild TBI, the traumatic brain injury, because of the risk of intracranial complications. Then emergency treat department for the assessment if any loss of consciousness or any altered GCS. Hospitalization is usually with normal CT scan, but GCS is deranged or any bleeding disorder or abnormal CT scan. Early rehabilitation to maximize the outcome, like occupational therapy, physiotherapy, speech language physiotherapy, then vestibular therapy, driving, therapeutic. So in those cases, we can go for that one. Then pharmacological treatment for headaches. CBT is important because for the later on depression, relaxation therapies, and then return to the guidelines. So you can go www.thinkfirst.ca. Prognosis. What is the main prognosis? May occur from the mild is basically with minimal treatment, but some experience late on consequences. What are those ones like depression, seizures, and all of those ones? Patient with the previous concussions or at a higher risk of subsequent concussion and cumulative brain injury. So repetitive TBI can lead to a life-threatening cerebral edema. So this can be asked. A patient had a injury before and now he's having again. So what could be the main impact? So cerebral edema. Sequel is basically post-concussion syndrome. What are that ones? Dizziness, headache. So they can ask you to make a diagnosis of this one. Post-traumatic headache can be asked within 7 days. Post-traumatic epilepsy can be asked. And in this one, we go for the anticonvulsant and then post-traumatic vertigo. So the prognosis, you can read this one. Okay. Then let's go back to emergency medicine. I think where were we in emergency medicine? In endocrinology, all you have to do is thyroid and diabetes. Okay. So when you are reading the ortho uh, last videos, the second video, I try to add some more things in that one. So, if you have time, so I would suggest to go through that video again, the second one, okay? Okay. Okay, so I think we were here on this one topic. So let's do from here as well, like the stroke and then transient ischemic attack. So we already discussed the stroke, how much you need to know about the stroke. So severe causes of emboli from the heart is basically atrial fibrillation, MI, endocarditis. In these cases, they can give you a case of stroke related to this one, like a patient has a dilated endocardiopathy, prosthetic valve, or something like that, that can lead you toward the diagnosis of stroke. So that's why the 7 causes of emboli. So what are the signs and symptoms? You can read this one, then stroke this one. Then comes the investigation. We already discussed CBC, electrolytes, blood glucose, just to find out this is 100% stroke or something else is there. Then how you are going to manage ABCs. starting with the intubation. Usually, the stroke presentation can be only asked in emergency, but can be discussed in family medicine as well. Intubation with the rapid sequence survey index. If the GCS is less than 8, then you have to check for other things too. Then the thrombolytics, that TPA is given. Then the antiplatelet, we already gone through this one for 21 days, elevating head. So just when you're talking about the treatment of stroke, do keep your mind about ICP as well. So you might have to write down the treatment for ICP. Or maybe they can ask you, or they're asking you in the MCQs about the treatment of ICP, although they're giving you treatment, they get diagnosis of stroke. So elevating head for the ICP is aspiration or worsening cardiopulmonary. Then NPO is important, IV plus cardiac monitoring, BP control, glycemic control, then cerebral edema control with a hyperventilation and mannitol. Then the consult neurosurgery and then antiplatelet and consider the anticoagulation, follow for the consideration of the carotid and arterectomy. So you can see in the sidebars where are the absolute exclusion criteria for TPA, like having any bleeding disorder, just to keep the simple. Bleeding disorder, any previous injury, any blood glucose lower, so any kind of hemorrhage. So this is just that one. Then the relative one is basically a pregnancy, GI disorder, or GI hemorrhage. Mainly the hemorrhage is the one, and then seizures. Then the otolaryngology is basically in this one. We will do acute otitis media. That's very, very important, especially in pediatrics. So when we will do pediatrics, we'll cover it from there. But here, if there is otalgia, we can go for culture and sensitivity of the ear if there is any discharge. Then otherwise, giving antibiotics. In hearing loss, we usually don't do much, just sending for audiogram and referring to the ENT specialist. Then the epistaxis, the how you approach the epistaxis is very important. What are the complications of epistaxis? So complications of the nasal packing, like what is the complication of nasal packing is important because this is the main treatment for epistaxis and what it can cause. So hypoxemia, toxic shock syndrome is one of the most important because it can be covered in dermatology too by giving you a picture of toxic shock syndrome and now asking you what could be the cause, or a patient was having epistaxis, he recently got a treatment, but now he has a skin disease going on, and they explained the toxic shock syndrome, and now they are asking you what could be the cause. So nasal packing, right? They are asking for nasal packing. Aspiration, pharyngeal fibrosis or stenosis, and then septal necrosis. Then the treatment goal of the treatment is localize the bleeding and achieve the hemostasis. So in this one, you have to rule out PTINR just to check for the bleeding disorder. First aid is ABCs, clear clots by blowing the nose, and then lean forward, pinch cartilaginous proportion of the nose for 20 minutes, then assess the blood loss. If first aid measures fail, then continue with the packing. So don't directly jump to the packing. Then there is an anterior packing and there is posterior packing. Usually anterior packing is done by an emergency physician and posterior is done by some later on. May be placed by our emergency one, but it's mainly placed by some sort of surgeon. So in the anterior one, just giving the anesthesia and then putting the Vaseline gauze. Disposition is in the emergency. The important is when you are going to discharge the patient and when you are going to admit the patient. That's important. Discharge upon stabilization and admission is basically when the refractory bleeding. So when we'll do gynecology, we'll cover the bleeding from there. So the approach is same. If you can see ABC is going for ultrasound, finding out beta HCG. So don't forget about beta HCG wherever you are doing it. And then whenever we are talking about vaginal bleeding in pregnancy, don't forget about Rh immunoglobulin, ROGAM, okay? And Rh negative, think about this one too. So 3, 4 main words, ABC, tetanus, Rh immunoglobulin, beta HCG. So keep these things in your head. Wherever it applies, just give it. Renal stones are important. We will do it from urology. It's written more nicely there. But yeah, you can read it from here as well as compared to the management is just the NSAIDs anyway. Then ophthalmologic emergencies. We are doing it from here because it's important topic because we are not doing it from eye anyway. So that's why you have to cover it from here. So the main, if you go to ophthalmology, I cannot go right now. So if you go to ophthalmology, let me just open it. Wait a second. I can. So yeah, if we go to ophthalmology here, so there is a table in the first, I think in the first 3, 4 pages. Just okay. I'm talking about this one. The common differential diagnosis of the red eye. So this one you can read it from here. That's more than enough. Okay. So this one you have to do it from here. So it will give you a coverage of everything that you need to know from eye. Okay. So conjunctivitis, acute iritis, acute glaucoma, keratitis. What are the discharge? How does the pain look like? How does which one has photophobia? Which one has pupil problem, injection, then cornea, intraocular pressure, anterior chamber, nausea, vomiting. So in this one, you can see what are the most common differential diagnosis of red eye. Okay, so it will cover your eye. You don't need to do a lot of it. Okay. Then comes the ophthalmologic emergencies. So it's mainly whenever anybody in emergency department comes with a foreign body in the eye. So usually we start with the QPS irrigation. So mainly the word QPS irrigation with the saline, not with the water. With the saline for any foreign body. Remove the foreign body under the slit lamp examination with the cotton lamp and then steroid needle. Even if this patient presents in family medicine, the approach will be same to you. Okay. QPS irrigation with the saline because that's something that you can do in family medicine too. Okay. Then remove the foreign body antibiotic drops like Tobradex. Patching may not improve the healing. So limit use of topical anesthesia. So the saline, removing the foreign body into the slit lamp, and if you are not able to do anything, then referring to the optometrist. Then tetanus prophylaxis, as I said, ophthalmologic globe if the globe penetration suspected. So just knowing the diagnosis of any kind of eye disease is more than enough for you. Then the contraindication of the pupil dilation, when are you not going to do it? Shallow anterior chamber, iris, potential neurological abnormality or the question with the CV disease. In this one, it's important if you see what are the causes of it and how does they look like. Why? Because it can be given in a scenario where they can give you a patient has been using a phenytoin for too long and now he's having this skin peeling off or stuff like that. So you need to know this is a Steven-Johnson syndrome or toxic epidural dermal necrosis. Or how does the picture look like or how does the person look like? Then the staphylococcal scalded skin syndrome. Please, whenever you are reading any dermatology, make sure you see from Google how does it look like. So staphylococcal scalded skin syndrome causes by exotoxin. So it comes with fever, arthralgia, and mostly common in children's. So what happened in this one, skin is red, warm, and very tender. Usually you don't need to do any treatment or anything like that. Just knowing that diagnosis is more than enough. Then the Steven-Johnson syndrome or toxic epidermal necrolysis can be caused by the drugs, bone marrow, or transplantation. Which drugs can cause? Penicillin, NSAIDs, sulfa, phenytoin. So a lot of patient from penicillin who does not know that he was having a like a tree like hypersensitivity with the penicillin and now they develop this one. Okay. So in this one, even the severe mucous membrane blistering too. Then comes the toxic shock syndrome. As I said, it's very important if there is any like foreign body, like females who use tampons or like any foreign body that's injected into the body, like nasal packing, that can be one of the cause for the leading towards this one. Then erythema multiforme, immunological reaction to the herpes simplex. So it's mainly come from this one. There is a large bullous there. Then pyoderma gangrenosum, because they all kind of look similar. That's why the causes is important, so you can find out how or where is it coming from, so you can make the diagnosis easily. So it's mainly occur in the arms, hand and feet. There is a bulla formation or vesicle or pustule is there. Then disseminated gonococcal infection. It's very, very important because of the sexually transmitted infection point of view and from the septic arthritis point of view too. Okay, most common in the gonococcal, and then skin lesions usually appear in the extremities. Meningococcemia, it's mainly headache and all related to the meninges. So usually the treatment is IV fluid, electrolyte, and then transferring the patient to the burn unit. Or usually the plastic surgeon is the one who controls this patient. So you can see this one mainly where the coming from the, like, if where is it coming from, the some sort of transplantation or immunocompromise. In those cases they give steroids, like as you can see here, or stop the medication fluids, giving steroid to stabilize the patient for a while. But in the patient who is coming from the bacterial, they are giving IV antibiotics. So just keep that in your head. So TEN is important too. Why? Because just to give you an idea, just give me a second. The TEN is important in this way because it could be mixed with the other one, and you need to know how does it look like. So it's very, very important. So that's why the TEN. So as you can see, the TEN and the Steven Johnson syndrome, they both are very, very, like, not very common questions, but if you are the lucky one and you got this question, so it will be hard for you to differentiate between them. So in that cases, you need to know. Okay. Um, that's about it. Here comes the one of the most important topic of the emergency medicine. So what is heat stroke and what is heat exhaustion? Just this table is enough. Okay. So you can see the heat exhaustion and the classical heat stroke and exertional heat stroke. A lot of patients do present in a family medicine practice or in the emergency medicine practice where they say, oh, I'm having a heat stroke, or I'm having a, like, usually they say heat stroke. They don't go for heat exhaustion. So in that cases, how you are going to manage or approach that person. So first of all, making the diagnosis, you need to know that it is a heat stroke or it is not a heat stroke. So a body temperature less than 40 is basically heat exhaustion. If it's more than 40, it's basically heat stroke. Just to an idea. If there is no coma, no seizures, no dehydration, like there is mild dehydration, then it's an exhaustion. But if there is more than dehydration, like a mental confusion, I was dizzy at that time, I had a little bit of like confusion at that time, I wasn't able to stand for too long, that can give you an idea about what is the exhaustion and what is a stroke. Okay. So then a heat wave or poor ventilation and maybe altered liver enzymes. Okay. So whenever they ask for what is the blood work or what is the test you would like to do for the heat stroke, in those cases people go for electrolytes. It's important to do the electrolytes. It's not like you can miss it out, but mainly the liver enzymes that got little elevated in heat stroke. Then comes the exertional one, is basically, when they go to gym and after coming from the gym or from the work activity, so all of these things. So people usually are young ones. And in this one, what are those ones? It can lead toward DIC, acute renal failure, and lactic acidosis. So is important. Okay. Then comes the treatment in exhaustion. You can give IV fluids if he has dehydrated symptoms, cool temperature, and all of that. Then comes the classical and the exertional. In both of them, you have to cool down the body temperature. Then giving them the standing fans, secure airway because if he's having seizure or any delirium or coma, then giving the fluids because mainly the dehydration is there, and then avoiding all kind of, like, vasoconstrictors. This line is very, very important because a lot of us do like to give these things when the patient heart rate is getting low and all that. So in the heat stroke patient, we don't give any agonist like the vasoconstrictors or any epinephrine to bring up the heartbeat. Um, Mainly in the hypothermia, you also need to know what are the labs that you need to do and what are the complications it can cause. It can cause coagulopathy. Acidosis is one of the most important thing. Wherever you see, if it's a lactic acidosis, metabolic acidosis, you just need to correlate it with which kind of disease is it and keep it in your back of your head. Dysrhythmias, volume, electrolyte depletion. Then the labs is basically CBC, the venous blood gases, checking for the creatinine bun, magnesium, calcium, all of these ones, and the lactate as well. Then doing the chest X-ray to finding out if there is pneumonia and all leading towards that. Now, this one is very, very important. What are the rewarming options? Okay. And which one is the active one? Sorry, active external one, which one is the active core one, and where do you have to apply these ones? Okay, so give gentle fluid and electrolyte replacement in all cases, passive external rewarming, active external rewarming. It's suitable for the stable patient. So you can think of if the patient has a suitable temperature more than 32, in those cases, we go for external rewarming. Where what is the external rewarming? Giving a like an insulating blanket. Body generates heat and rewarms through the metabolic process. Then comes the active external rewarming. In those cases, it's very important to be aware of the after draw. So that's why involve use of the warming blanket and when done in the congestion with the active core rewarming. So it has to be done with active core rewarming. Generally for the patient, which one? You can just remember the temperature. On the basis of the temperature, which can be given. And with the cardiovascular instability, avoid the after drop seen with the active rewarming. Okay. So the rewarm course by using the fluids. So internal rewarming, all of the warm fluid, gastric lavage, or the colonic irrigation, and then external circulation. In the cases of the cardiac arrest, it is important as is one of the MCQs usually comes from this arrest, hypothermia, and from the burn. Okay. Do all the procedures gently and may precipitate the ventricular fibrillation. Check for the pulse and the rhythm for at least 1 minute. May perform bradycardia. If any pulse at all, do not do CPR. If in ventricular fibrillation, try to defibrillate up to maximum of 3 shocks. Intubate if required. Ventilate with the warmed, humidified oxygen. In the cases where they give the medications may not be effective and may try only one dose if you feel like doing it. Focus of the treatment is rewarming. Then the frostbite, so how you're going to approach, how much it is. So treatment with the hypothermia, oxygen, IV fluid, remove the wet and constricted clothes. It's very important. Then immerse, because usually we do started oxygen, IV fluid, and we forgot about removing the wet and constricted clothes. Then immerse with the 40 to 42-degree temperature. Then clean injured area, aspiration, debridement, debride the skin, tetanus prophylaxis, as I said, then consider the penicillin G and surgical intervention. Now comes the burn. It's very important, this rule of 9. You have to, sometime they can give you a picture and you have to calculate. Like I got an MCQs from here where I have to calculate the surface area. Okay. So you need to remember it because they don't give you this picture. They can give you a patient had a burn, half of his skin was burned up to elbow, head, and the front of the chest. What is the surface area and how will you manage it? So one MCQs was calculating the surface area and the second MCQs was managing it. So burn size rule of 9 do not include the first degree. So then the burn depth, how much it is, and they can give you the burn depth too, how much it is. So on the basis of it's a second degree, third degree, you will get an idea how you are going to approach it. Management is basically this one. Remove the noxious agent and stop burning process first, then moving on to the next. Consider appropriate PPEs, establish airway, resuscitation of the second and third degrees. Then the Parkland formula, very, very, very important. This was one they were looking from like for my MCQs. They were looking for this Parkland formula. Okay. So the Parkland formula, you need to know how to calculate it because they can give you and ask you how to treat it, basically asking for the Parkland formula or you know how much to fluid because they can give you BSA or they can ask you to calculate the BSA and they can give you a kgs and then asking you to calculate or how much you are going to give. And not just this, they can ask you up to in what are you going to give in the first 8 hours. Our first 8 hour fluid is given. Now tell what is the next 16-hour fluid. So, it can be made in different ways. So 4 cc per kg per percentage of the body surface area burned. Then the urinary output is the best measure of resuscitation, should be 40 to 50. Pain relief, it's important, this 40 to 50. Pain relief, giving opioids and investigation CBC, burn wound care, prevent the infection, clean, debride, eschorotomy and fasciotomy for the compartment syndrome. Then the topical antibiotics and tetanus prophylaxis, as we already discussed this one. In inhalation injury, what is important is basically later on developing edema. So in this cases, you are going to start with the intubation. So in that cases, they can ask you what is the prevention or what would you like to see. So ask for always look for inhalation injuries patient with the burns, intubate early. That's what they want. Okay. If suspect inhalation injury, as airways can become the obstructed due to edema. So CO2 poisoning, 100% oxygen plus hyperbaric oxygen. Then the direct thermal injury. Then comes the bite. So you can read what are the bites and how you are going to start. So starting with the cleaning, the wound and debridement. Debridement is important. Culture and sensitivity if there is an infection. Mainly in the prophylactic antibiotics, we usually start with amoxiclav like amoxicillin plus clavulanic acid in many of the cases when it relates to the skin. Okay. Or the main treatment is basically amoxicillin in many of the cases, not all. Near drowning is important in children's, especially the pediatrics, most common in the children less than 4 years. It can cause the lung damage, hypoxia, and then hypoxic encephalopathy. So they can ask you what is the complication of it. May be assessed for the shock, C-spine injuries, hypothermia, scuba related one. Then what are the complications? Important electrolyte abnormalities. Which electrolyte abnormalities? Just not electrolyte abnormalities. Is it an acidosis? Is it an alkalosis? Is it respiratory? Is it a metabolic? So you need to know. Then physical examination. Before starting physical examination, start with airway, breathing, circulation. Treat for the trauma, shock, hypothermia, cardiac or oxygen monitors. Then we are going to start with the ventilator assistant, sorry. If decreased respiration may require the intubation, high flow oxygen can be given. In the bronchospasm, we give bronchodilators. Then one of the most important topic, but most easy. Just make the concept of toxicology and you are good. So let's try to cover it. The indications of suspected overdose, mainly what happened is altered level of consciousness, young patients with a life-threatening trauma or bizarre feelings. In this one, the mainly you need to know this part here. A, B, C, D, E, D3, E, F, G. What is A? Airway, breathing, circulation. So after that, what is that one? Drugs, draw blood, decontamination, exposure, full vitals, ECG monitor, Foley's X-ray, and then giving the antidotes. So here is one of the questions that can be asked, like, drug screening. Usually we think that the urine test is more comfortable and easy to do the drug screening. But according to books, the blood one is more quicker as compared to the urine one. So if you get a chance of having some sort of MCQs, so you need to know where you are going to do which one. Then obviously starting with the reassess. So after following all of that, reassess, call for the poison informative center. Don't forget this one. And it's important you have to report it. So reporting. Obtain cooperative history from family and bystanders. What are the principles? Resuscitation, screening, the clinical doses, and then the decrease the absorption of the drug and increase the elimination of the drug. So first thing first is basically resuscitation. Then these are the universal antidotes: DONT, dextrose, oxygen, naloxone, thiamine. You don't need to know how much you have to give. Just remember, these are the one we actually inject into every patient. Wherever you feel, wherever you feel there is a drug abuse going on, or sorry, uh, any drug misuse happened or any toxicology happened. So then, this basically you give oxygen just to make sure. Then naloxone in the patients, we are giving the antidote for the opioids. Then comes the thiamine, mainly in the patient with the alcohol. Thiamine is deficient in malnourished, considered in the patients with alcohol use, as I said, uh, homeless or someone who is not having good nutrition. So in those cases, or in the indigenous people who are coming from reserves, even those patients too. So just not homeless, but indigenous, you can consider the same antidote, or same things that you consider for alcoholic. Think of, if they give you an indigenous particularly, think of the same diseases in those one too. So drug urine screen is costly and generally not resultant, sorry, not helpful in the ED of the poison patients unless the suspicious of ASA, acetaminophen ethanol ingestion. Then doing the blood checking for everything wherever it's possible. Then the serum drug levels, treat the patient, not the drug level. That's why we said go for don't. The negative toxicology screen does not rule out the toxic ingestion. So maybe he's used some drug which has a strong life efficacy. So it does not rule out anything. Specific drug available on the drug screen, and then urine lab screens also available. Now, this table, you have to remember it on fingertips. I don't know, there is no shortcut to it. There isn't anything that I find anything helpful. So, you might remember these gold mark, but you still have to remember what does it stand for. So in what happened in the metabolic acidosis, there is metabolic increase in iron gap, and there is a decrease in iron gap, and there is a normal in iron gap. So which one is which one? So you need to know. So mainly the glycols, uh, the oxoproline, lactate, methanol, aspirin, renal failure, ketoacidosis, these are the one that can be in the increase in iron gap. Decrease one is mainly comes with the electrolyte. So you can think of wherever the electrolyte is disturbed and the lithium. Okay. Then the normal anion gap is basically with the bicarbonate problem. Then here one of the thing was ABGs, electrolytes, glucose, sustainable ECG. In which cases or which drugs you have to do the ECG. Okay? Just give it a quick read. Maybe a question can be asked where the patient was given quinidine and what are the investigation that you would like to do. Okay? Although we do other things too, but ECG is one of the things that you'd like to do to figure out if there is any arrhythmias. And a 9-gap formula. They can give you a scenario where you have to calculate the 9-gap. Then the decontamination and enhanced elimination. So ocular decontamination, dermal decontamination, then gastrointestinal decontamination. Ocular, where we do the saline, we already discussed. Dermal, where we do the protective one. And then gastrointestinal, where we give the single dose of activated charcoal. And then whole bowel irrigation. So just for your reading. Multi-dose activated charcoal, surgical removal. So in which cases we are going to do the lipid emulsification? In the patients where the patient was having, maybe used for the anesthesia, beta blockers, calcium channel blockers, or any antidepressant. So in those cases, we did the lipid emulsification. Then the urine alkalinization may be used for which kind of drugs. So the drugs are important. For which drugs we give what kind of the treatment. So lipid one, knowing only this one. What are the drugs? Anesthesia, beta blockers, calcium channel blockers, atypical antidepressant. In those one, we do the lipid emulsification. In the urine alkalinization, which one? The aspirin, methotrexate, phenobarbital, chlorphropamide. In those ones, we do the urine. And it's important. They can be asked in MCQs. In the hemodialysis,